elbow, again, we're going to check for any deformities, any carrying angle issues. Going to check active range of motion, so have them extend and flex all the way. That's good. Have them put the arms up like this, pronate, supinate. Good. Bring your arms down to your side. Okay. Now, I'm going to check for palpatory, check the radial head, check the joint lines, check the olecranon. Okay, and we'll do is a balance test. I'll check for the capsule. I'll kind of move into the ulna, go from medial to lateral, so I'll check the ulna, collateral. I'll come here both 0 and 30 to 60. I'll check for any endpoint, any laxity. It's called the milking maneuver. Check the radial head, and then as well, we'll check the posterior interosseous nerve and the lateral epicondyle for pain with tennis elbow or posterior interosseous nerve entrapment. Same thing with the ulnar nerve. Check for tenelles over that as well. Okay. Other provocative tests, the radiocapitellar compression testing. If you see OCD, some of your baseball players, they have a fusion. Put their hands together, again stressing the ulnar collateral, push them again real hard. It's called the milking maneuver. They may have pain along that area. Flexor pronator symptoms, if they have flexor pronator strain, they'll have pain off the joint line, and they may say they have pain that radiates down. The same with the medial epicondyle. So we'll check motor strength, sensory reflexes, go ahead and push. They may have pain with the extension, hands out. Do a good neuro exam. Have good lumbrical adduction. Go ahead and keep your fingers out. Good. They should have good strength. Sometimes an ulnar nerve injury, they'll have weakness with that. They'll have atrophy. So look for atrophy and muscle weakness in any of the compartments of the radial, median ulnar nerve. Moving on to the wrist. Again, you have tenelles over the median nerve, over the ulnar. And again, the radial is up in here. You can follow along. Looking for weakness again. You move into the wrist, the Finkelstein's maneuver for the Corvain tenosynovitis. You're also checking the dorsal compartments, looking for any crepitus, like intersection syndrome, which has a crepitus along the different tendons. They'll have pain. See that in your wrestlers and your weightlifters and rowers. Checking all the metacarpals. Make sure there's no deformities. Your carpal bones. This is called a Watson. Radial ulnar deviation, volar, and dorsiflexion. Elicit some pain and click. Usually an injury, fall, stretched hand. Scaphoid tenderness for snuff box. Scaphoid shift test. You're kind of pushing up on the scaphoid for a stress fracture. Tenderness over the scapholunate junction. Again, it's a ligament injury. Lunate, again, cold stress fractures in the lunate. They have avascular necrosis. They can have pain there. Into the phalanges, the metacarpal phalangeal joints. Checking for synovitis, especially in arthritis. Rheumatoid affects the MCPs, and it is spared the DIPs. Look for any spongy feeling. Do a joint count. Looking for mallet deformities or swan neck deformities, extensor tendon. As the clinical history would check, go ahead and push up against. You're always going to check strength at each level. Okay, and then flexion too. And you go about that with any inherent finger injury. So that's about it for that.
Okay.
On the hip, going to check. Obviously, we've done the gait exam like we did with the previous tests. We're going to look at their standing hip exam, both anterior and posterior. I'm going to move into, I usually go right into the supine exam, check for leg length discrepancies, put your fingers on the hand, thumbs on the malleoli, go ahead and sit up all the way. Go ahead and lay back. So it's just a little bit of a leg length discrepancy with seating, so you're determining whether it's sacroiliac or sacral. And then I'll check just general, again, range of motion, passively. And I'll check in external and internal rotation, elicit any pain, any reduced range of motion. Femoroacetabular impingement testing. I'll try to elicit hip impingement. Fitzgerald's test for labrum, which is kind of almost like the McMurrays of the hip. Okay, a fulcrum test. Check for any distraction, possible stress fractures. And that log roll, again, talking about fractures of the femoral neck. Checking, obviously, doing your alignment. So looking at the ASIS, tenseness of the hip flexor, the rectus femoris, iliac crest heights. And flip onto your stomach. Same thing, and do the sacrum. Check the sacral sulci. After checking for a standing flexion test and see if she's got any, which torsion she has, and I'll move up into the lumbar. Again, check for probably a group deformity. Usually a group deformity presents with a sacrum. So, and we'll do a palpatory exam. Check the sacrotuberous ligaments. That usually goes hand in hand with the ILA deformity. Oh, she's got a little tight on that one. And then flip onto your side now.
Right.
On your left side. Last thing I'll do, and then you can palpate the troch. If they're having tenderness or the trochanteric bursa into the tensor fascia IT band, then I'll do a modified over test. Go ahead and keep your leg up. Don't let it push down. And that may elicit some pain. Depends on if it's proximal or distal. If it's a distal IT band, then that's probably more bursitis and tendonitis, not just tendonitis that is above. So good.
Yep.
And so the neck, again, neck you're looking at making sure they have a good lordotic curve. It's not too much cervical thoracic kyphoscoliosis. You want to get the thoracic spine involved. So we're going to get a good view and feel. Go ahead and bend forward gradually. Make sure she doesn't have any abnormalities with her curve. Looking for ass-shaped deformities, her carrying angle of her shoulders. Looking for step-offs for deformities on her neck. And then palpatory, looking at any abnormal muscle spasm. Do some general range of motion, extension, flexion, both active and passively, side bending, and then rotation at neutral. And then from there we can move into some muscle testing. Go ahead and push forward, push back, to the right, to the left. Okay, and all that's fine, and we go into some provocative testing. You can check Sperling's maneuver, ipsilateral neuroforaminal illicitness, see if she gets any arm pain with that, or a disc pathology would present. And we'll do a good neurovascular exam of the upper extremities, again looking for any atrophy, muscle weakness, sensory deficits. Make sure you get good reflexes in the neck. And we'll do that both sides. And then also, based on their history, we'll do a good cervical exam in the face too, make sure they don't have any high-level cervical pathology.